I think we can start, Clarissa.
Yes, I think so as well. So I just introduce everybody on our side, and then I will pass the torch to you, Clarissa. So my name is Tzvika Decker. I'm the business development manager for Israel, basically for everything, for all the franchise. I was marketeer of trauma and extremities a few months ago, and then I've changed role. And I'm working in Striker for a year and a half almost. And with me there is Inbal. She's the manager of the team for the IC in Israel, Army Technologies. Inbal Aziza, say hi.
Nice to meet you.
And with me in the room, Avi and On, two very professional sales rep that will work with the Perform Humeral. And we just received everything, all the sets, so it's really, everything is very, very new here. Smells like new and looked like new, so we are waiting for your training for us to start working with it. So thank you for that.
Yes, thank you for the introductions. And I'm Clarissa Kindig, and I'm on the upstream marketing team based out of the US. Been with the company on the upper extremities marketing team for a little over 7 years now. And I was able to persuade my a few counterparts to join me today. So I'll let them introduce themselves, but I was able to get an R&D colleague who was kind of the brains behind Perform Humeral. So if you have some very technical specific questions, Dave will be able to answer those. And then I also had Colorado Krugel join, who is the downstream manager in the US also. So I think between the three of us, we hope to get you very prepared for a launch in Israel. So Dave, do you want to go ahead and introduce yourself?
Yeah. So just to clarify, one of the brains behind Perform Humeral, not the only one, that's for sure. Like Clarissa said, I'm on the R&D team. I've been with Stryker for about 10 years now. I was, back when we started this project, I was the R&D lead for the STEM portion of the project. So it's been a few years, but I was very, very involved. And to Clarissa's point, if you have any technical questions, don't hesitate to reach out. Hopefully I can remember the answers to them at this point. If not, we can always find you the answers one way or the other. But yeah, happy to be here, happy to help out in whatever way I can.
Colorado, do you want to introduce yourself?
Sure, same as David. I'm happy to be here and speak with you guys. My name is Colorado Krugel. I've been with Stryker for a little over 4 years now, with 3 of those years to begin with, starting on the sales side of things in a different division. So came over to the marketing side with upper extremities, been here for about a year now, worked a lot with Clarissa and David. And so if you guys have any questions, I will try to answer them, but Clarissa and David will probably answer them before me. So nice to meet everyone.
All right. I see a few other faces, if you want to do quick introductions, or we can get started, whichever you prefer.
Maybe I'll start. My name is Moshe Lupo, and I'm the head of the orthopedic division in AMI, distributor of Stryker here in Israel. Inbal?
Hey, nice to meet you.
Inbal, you're muting.
My name is Inbal Aziza. I'm working at AMI 4.5 years. And we have 3 sales reps, special sales reps, and we do all the total shoulder replacement and all the sport med in Stryker.
Wonderful.
Clarissa, myself, I'm Reinika. I'm responsible for the education in the EMEA area. So, a big thanks for Leandri putting this meeting together for us. And thank you for all the presenters. Really appreciate your time.
Good afternoon,
Afana?
everyone. Thought I should jump on. My name is Wafana Matita. I'm the product manager for trauma and extremities here in South Africa, working alongside with Renika on education. And we're quite excited because we are probably bringing the Perform Humeral into South Africa in the next coming months. So I have no doubt that this will be so valuable and very insightful. Thank you so much for extending the invitation to me as well. Appreciate it.
Wonderful. Well, it was nice to meet all of you, and we have some slides thrown together here to talk through Perform Humeral, but please feel free to interrupt and ask questions. You know, whatever we want to make this as successful for you as possible. So, like I said, speak up, and then afterwards, I'll be happy to share the presentation or any other resources we've developed in the US or Europe that can help support your launches as well. So just please feel free to speak up. So I'll go ahead and share my screen here for you. All right, maybe. All right, so quick agenda. We thought we'd go over kind of the system overview, the major inputs into how and why we design Perform Humeral. Quick look at each of the implants, your stems, your heads, your polys, a surgical overview step, the instruments, which you have in front of you, which is awesome. It'll make it a lot easier to talk through. So good work there. Tips and pearls that we've learned the hard way in the US after launching that we hope will make it a little easier of a transition for you. And then some US sales data, so you can kind of see where our size ranges have fallen. We found that to be pretty helpful in some other international launches. So we will go ahead and kind of jump in. And Dave, Colorado, please don't let me speak the whole time. You're welcome to jump in, but there were kind of these 5 main bullet points when designing Perform Humeral. So we'll just start at the top, was to integrate stem and stemless instrumentation. So we wanted, for those of you that are familiar, you have Flex, and then we also had a stemless option here in the States called Simplicity. And they all had their own instruments. They carried their own implant inventory. And we wanted to find a way to bring instrumentation together to support stem, stemless, anatomic, and reverse, all out of 2 primary trays. So that was a large input in the US, as well as global feedback that fewer trays, the better to bring into the OR, especially from a sterilization standpoint. That second one in sort of the brown color, streamline your inventory offering. From a business perspective, there was a large initiative to create shared components between your heads and your inserts. So again, all of our predicate systems in Flex and Simplicity, and even the older ones, had their own inserts, their own humeral heads, whereas the heads and inserts that were designed with Perform Humeral will work across our stemless option, fracture, and HRS or Revive. I'm not sure what's all available in your market, at least yet, hopefully soon, if not now, but to create those shared components. And we'll look at that here in a minute. Expand addressable patient population. So this was a huge input for the project, along with our design surgeons, was that we needed to make a system that was a global solution. So we recognized that Flex, even a size 1, oftentimes is too big, especially for those smaller elderly females with difficult anatomy. So part of Perform Humeral was to design either a smaller stem in general, so collar diameter all the way down to the distal portion of the stem. And again, we'll dig into more of these. So large input from a global perspective for Perform Humeral. And then improve reverse biomechanics. So when Flex was designed a number of years ago, it was designed as an anatomic stem. That was really the bulk of the market. However, I'm sure as you all know, the market's heavily reversed these days. So Dave and team wanted to design a stem, that was really more reverse minded. And then the last one, offer more bearing material choices. I'm not sure, again, in your market, but at least in the US, there was a strong push to have vitamin E polyethylene, which wasn't something we carried before. So that was something we launched in the US. I know we're trying to get that launched more globally. Some challenges with BSI and CE mark, and that they need more data to get them in some of our international markets. So I haven't touched base with Leandri on what will be available in your markets, but at least you have conventional and vitamin E in the US, conventional in Europe and other markets at this point, and then hopefully vitamin E coming soon for everybody. Dave, is there anything else you would add here?
No, I think that pretty well covers it. It's a lot of information. If there's specific questions about how did we integrate stem or stemless, or what did we do to improve reverse biomechanics, things like that, just please ask those questions. We're happy to provide details where possible and necessary.
Yeah, and we'll do our best to dig into some of it. And I do apologize if there are things that are not available in your market. I feel like it's a kid at a candy store and I'm taking candy from you. But I also think it's good to see the whole picture as it comes together. And I know Landry's working very hard to get a lot of these products that aren't available within markets. So when I talked about shared components, you can kind of see in the gold box in the middle of the screen our head options and our poly options. And so you can see with Perform Stem there, all of these will work on the stem with for the heads on stemless as well. We have our fracture stem there to the right and not pictured as our revision stem in HRS. But this, from an inventory standpoint, both in hospitals as well as on the business side, has been super beneficial to be able to share polys and heads across all of our humeral systems. There are a lot of options. So our heads are modular. We'll dig into that also. So you have a number of head options. And then from reverse inserts, a number of options also. Some love all the options, some do not, but we will talk through those in a bit. But it has been extremely beneficial from a business standpoint as well as a customer standpoint to have these work across all of our humeral systems, so you have what you need in a hospital when you need it. So let's jump into the stem here. So we'll kind of work, left to right and around. So we do offer standard and plus size stems. This is something we've not done quite before. And again, a lot of this we'll dig into the details, but please ask questions if it's confusing. Essentially, the plus size stem is just slightly bigger to allow a bit more press fit if you don't want to go up an entire size. And we'll get into those details. And then you can kind of see moving to the right, the medial collar there to help with load transfer. So help with bone resorption there around the collar. A big input from Dr. Athwal and some of the studies that he has done. Again, moving right, you have your 4 collar diameters. So these 4 collar diameters are shared across a family of sizes that are also shared with stem and stemless. The metaphyseal area, it does have plasma pore spray to help with potential osseointegration. And then you can see down towards the distal part of the stem, it is smooth. So Perform Humeral is indicated for cement or cementless use, up to your preference. The US, we tend to do a lot of things uncemented. However, we know in Europe, they use a lot of cement. So I'm not sure if anyone wants to come off mute, but what's used in your market? Do you see cementless, cemented? Is there a preference?
I think certainly for the South African market, you often see a good mix of cemented and uncemented, especially when it comes to the send stems. A greater majority of surgeons would, in ideal, cement older patients, but often at times I think the option to go uncemented is often a preferred alternative than cemented.
Okay, sounds very similar to the US. They'll use cement if they feel like they need it or they're not quite getting the press fit they'd like, but they certainly prefer press fit. So with this stem, you have either option.
Can I just make one quick comment?
Yeah, please.
So one difference, and again, this helps to streamline the system and just to reduce the number of decisions that have to be made. With Ascend Flex, you had separate cemented stems and cementless stems. The cemented stems were a highly polished titanium, and we've gone away from that. So our stems, it's just one line of stems to be used in either a cemented or cementless fashion. And one of the things we did with this, that distal surface, if you think to Ascend Flex, the cementless stems with the titanium plasma spray coating, the distal surface on those, while it's not plasma sprayed, it's still very gritty and rough. From what I understand, that can cause challenges if you have to cement that and then remove it at some point. And so what we've done, the distal stem for Perform Humeral it's not highly polished, but it's much more smooth than the distal stem for Ascend Flex. So it's really a better, I guess, we're finding common ground between the two Ascend Flex stems. So hopefully one stem provides good options for both cemented and cementless, if that makes sense.
Yeah, great call out, Dave. So then the last two here, you can kind of see that medial fin, again, rotational stability. And then the last also here, the tapered distal stem for reduced filling ratios, recognizing that it is a smaller stem. We're not trying to go after kind of the distal filling ratios with the bone resorption and all the data around that. And you'll get to see more. And if you have implants in front of you, you can see how much smaller it actually is than when you compare it to Flex. So I don't have the image here to show it, but I'll send this deck out to all of you afterwards. And I threw a couple extra slides that we won't talk through today. But essentially, when you line it up with Flex, you're getting 3 smaller sizes than you would currently. And it's kind of a cool visual to see just in how reduced kind of that distal part of the stem actually is. So when we talk about stem sizing, and Dave, I may have you jump in here and help, but you can see, so the 32, 34, 38, and 42, those are the collar diameters. So those are shared across stem and stemless. Those are the only 4 we have. But typically you would see very linear sizing when it comes to stems, right? 1, 2, 3, 4, what have you. We kind of operated more in this kind of family design in that we have your 1 plus, and then a 1 plus long. All of those share the same collar diameter, but serve different purposes. So you may have your size 1, and it's say the collar diameter fits really well, sized perfectly within the metaphysis, but it still feels slightly loose, or you're not getting the great press fit that you'd like. That's when you could go to that 1 plus just to get a little bit of incremental press fit. And then you have your long stem. So it's more, and it's a bit misleading. It's sort of a standard length stem, just longer than our short stem. So you have all of those options within the size 1 category. So within the 32 millimeter bowl, it's the same as you work through each of these. However, you will notice there are 2 extra long stems within the 34 and 38 collar diameters. Those were really designed from sales field input, that they just need an option as a bailout solution. They have Perform Humeral in there. Something doesn't work well, there's an unexpected fracture or what have you. They have a extra long stem in there that they could cement in place. But the takeaway from this slide is that it kind of operates in more of a family style of sizing. So recognizing that within 32 millimeters, you have a 1 plus, and a 1 plus long. Dave, would you want to go through? And I know we had a lot of background around this one. Is there anything else you'd like to add when we designed all of these?
I don't think so. I mean, I think you covered it really well. The plus sizing is something that came a little bit later in the project, but is very, very widely used. And to Clarissa's point, typically what we see from a surgical technique standpoint is, you'll size for your collar, and then when they utilize the trial for that particular step, they'll kind of assess the stability of the trial. And if it's really good, that's the implant they'll use. But to Clarissa's point, the plus sizes come in handy where if the trial just does not feel like it's getting great fixation, they'll just jump immediately to the plus size implant typically. And that gives you about another 1.5 millimeters of press fit. And that's the technique that we validated, and it works very well for our users. To her point, the extra long stems, that was kind of a combination of sales and our surgeon team. If you're in a case and you have a intraoperative fracture, rather than creating a significant delay in the procedure to go get a different instrument set and different implant system, you would have those 2 options there to bail you out. And the reason we chose a size 2 stem and a size 3 stem to offer those options, as we'll probably get into with sizing a little bit later, your glenosphere compatibilities are a little bit different depending on whether you're using a 1 and a 2 or a 3 and a 4. So by providing an extra long 2 and an extra long 3, that gives you an option for a extra long stem, regardless of what your glenoid construct looks like.
Does that make sense to everyone? Are there any questions? Good. Okay.
Yeah, we are happy. Thanks.
Yeah, Okay. And it will make even more sense as you get your hands on it and you're in cases and you see how this kind of works. We'll talk through, to Dave's point, some of the compactor to final stem, what some of that press fit difference is, kind of what we're seeing, what we have seen in the US. So we'll work through that. But the more, obviously, when you're in these cases, the more you're in those, the plus size becomes a blessing for sure. So looking again kind of at the standard versus plus stems, and you may have to zoom in. These might be easier once I send it to you to see kind of the outlines over here in these gold images. But again, the collar diameters are the same, but you can see where the additional measurements just increase slightly. So if you look at the image to the right where it's kind of that goldish color, yeah, it's your standard stem, and then the outline is the plus. So you can see just how like incrementally bigger it is in different aspects of the stem. So I won't read through these, but I figured this might be something just to take an eye or keep an eye on as you launch it. From my experience in Colorado, you're welcome to speak up here. Generally speaking, in the US, they've really just wanted to know what the press fit difference was, and if there is any kind of the length of it grows at all, which you can see here that it does. So these will just be something to keep in your back pocket as you launch. And again, I have more details in this slide that we won't talk through, but I'll share with you for you guys to review. And then we look at our humeral heads. So big takeaway here is that our humeral heads are modular. So, with Flex and Simplicity, right, they're monoblock. You have a ton of different options, though you have to carry a wide range of inventory. We recognized, like, as part of the initiative of the project, right, was to reduce inventory or at least streamline it where we could. So the team developed modular humeral heads. So you can't see in the picture, you'll see it here shortly, but kind of this component here, this tapered component, is separate from the actual humeral head. So we have 3 couplers centered, obviously a 0 millimeter offset, just perfectly centered. Your low is 1.5 and your high is 3.5. So that does give you a wide range of options that you are used to now. They're just not monoblock. So they will be separate pieces. And then to the right, this is the US commercial range. I'm not sure what, I know sometimes in different markets, there are certain heads are limited, but at least in the US, it's a 37 to a 56 with a couple of those as a special order option. So far, we've had really good feedback on the options that we have here. It shouldn't be anything too different than you're used to, outside of the fact that they are modular. So it will take, when you talk through your customers, it will take a couple extra seconds to talk them through the process of trialing and implanting. And then inserts. As I mentioned before, there's a lot going on with reverse inserts with this project. So we'll start here at the top, and so you can see here there are shared locking mechanisms between certain sizes. Dave kind of alluded to this when he offered also the extra long stems with size 2 and size 3. So you can look here to this chart on the right, which is very helpful. So you have your size 1 and 2s, and you can see which polys are offered within each glenosphere size also. So your 1 and 2s are going to work along with your 33, 36, and 39 spheres. When you get to size 3 and 4, you can see that you would work with your 36, 39, and 42. And Dave, I'm going to turn it over to you if you want to describe kind of why with the locking mechanism, why we had to do that.
Yeah, so to Clarissa's point, a lot of it had to do with inventory and just simplicity of the system. Trying to reduce the number of SKUs that have to be both manufactured by Stryker, but then also held at the hospital, at distributors, all those things. Trying to limit that as much as possible. So some of our surgeon input was, if I'm putting a size 3 or 4 stem, I'm never going to be using a size 33 glenosphere. I'm typically using the largest glenosphere I can get. And same thing with a size 1 and 2. Typically, those patients are small enough that you wouldn't ever be able to get a 42 millimeter sphere and to begin with. So that's one of the reasons. I would say the second reason why we did not pursue, in particular, a 42 millimeter glenosphere with the smaller sizes. You can see in these images in the chart, as your glenosphere size increases, you begin to have like an outward flare of the polyethylene. And when we modeled that and prototyped that with a 42 glenosphere, it just became a little bit unstable, just given the size disparity between the humeral anchor and the glenosphere sitting within that reversed insert. So those really are the primary two reasons why we opted for this sizing scheme.
All right, thank you. So then we'll move down to the next one. So the stem RSA, so your neck shaft angle, if you will. So there are symmetric polys, you can kind of see here in the image, and then 10-degree poly. So the option or the input for that was one, obviously, at least there's been a large push towards a 135-degree neck shaft angle, but there still are a number of surgeon customers that prefer a 145. So we really wanted to serve both philosophies and giving each of those surgeon customers an option to use what they prefer. So if they want a 135 neck shaft angle, they can use a symmetric poly. If they want a 145, they can use a 10-degree poly. Did increase inventory, but we have seen that be pretty beneficial across the board so far in the markets we've launched in. Thicknesses, +0, +3, +6. I should have mentioned this before. So the stem angle is, as you can see in the trays, if you look at the compactors even, it's a fixed angle 135. So it's not like flex where it's got a variable neck shaft angle that you can adjust. It is fixed at 135. So that's where when you use a symmetric poly, it stays at 135. If you use a 10-degree, it goes to 145. The thicknesses here, which is important to know, is that you are, with it being a flush lay stem, you are right at the level of resection. So if you use a +0, you are perfectly on the level of resection. That's where your articulation will be. If you use a +3, you are 3 millimeters above your level of resection, so on and so forth. That is an important difference moving from flex being an on-lay stem to this being an in-lay stem, and we'll continue to talk through that here in a bit. Materials I touched on earlier, conventional and vitamin E. And then we have capture ratios. So I'm not sure how familiar the team is with this, or if Leandri has talked through this with you. In the US, we decided that we were going to kind of rebrand what we called our inserts. And I have a whole slide dedicated to this. Colorado's done a really good job messaging this in the US. But previously, right, you had your standard inserts, you had your retentive inserts, and we're launching just now an ultra retentive poly. All of those words mean very different things with all of our competitors. And again, I will share some of the data and slides later on with you that we won't dig into the numbers now. That being said, we moved our standard polys to be called 45%, and kind of that's the capture of the glenosphere. Retentive became 55%, and then we'll move to a 65% just to have as available as an option. Lastly, we have a spacer. So if you're not quite getting the humeral buildup that you need, we offer a 9 millimeter spacer. So again, you attach the spacer to the stem. That's 9 millimeters. You would throw on one of your polys. So if you put on the +0, you're right at 9, right? You put on your 3, you're 12. Just to build up some humeral thickness should you need it. We don't see the spacer being used a lot, but every once in a while, something, doesn't go well in the case. The head cut wasn't as expected, and you'll see a spacer being used. But again, just provides an additional 9 millimeters of buildup on the humeral side. Bafana, sure, go ahead.
Yeah, just a quick question. When we're speaking about capture ratios, so in essence, this is how much of the glenosphere is captured in that insert at any given point in time. Would that be an accurate description of it?
Yes. Yeah,
Okay.
and Dave, the R&D team did a really good job kind of deciding the direction, along with our surgeon design team, the direction we're going and how to quantify this. That sounds very accurate to me, but Dave, if it's more technical than the equation here on the slide, the formula, please feel free to speak up.
No, I mean, that's essentially it. So what we consider constraint ratio, and that at least is relatively consistent amongst our competitors, is your liner depth. So your distance from the rim to the bottom of the articulation surface. Jump height is what some would call that term as well. So liner depth or jump height divided by the radius of your sphere. So if you've got a 42 millimeter sphere and your jump height, we'll say, is 10 millimeters, that constraint ratio would be 10 divided by the radius of the glenosphere, so 21 millimeters, if that makes sense.
But in short, Bafana, you got it right. That's kind of how we quantified it and how we've talked through it in the US. So far, it's been well received. It's driving good communication across the industry on what standard means, what retentive means. Because what we found, at least on like the legacy Tournier side of the business, is that most of our what we called retentive inserts was the same as the majority of our competitors' standard inserts. So when we launched Perform Humeral, we went from Flex being an inlet or being an onlay, usually a 145 with a standard poly and then moving to Perform Humeral as a 135 inlay stem. We were experiencing some instability concerns off the bat. And that's where we were like, what are we missing here? And there's a few things that we'll talk about that I think will help your team as you launch that we have solved here in the US, but we had a learning curve up front. One was realizing, maybe our polys aren't as, Dave, and you can help me out here, are as retentive, because our competitors weren't having these same issues. And what we recognize is that their standard polys were more retentive than ours. And it wasn't a conversation being had in the industry that our surgeon customers realized, like, what happens on the humeral side is just as important as what we're doing on the glenoid side. And we should all be speaking the same language here. And you can kind of see here on kind of educating the market on critical parameters. And it's not just the base plate you use. It should also be the measurements of your humeral insert as well. So it seems more complicated. Once you talk through it a few times, it starts to make more sense. But it is kind of, we relabeled all the polys. You'll see that once you look at those poly boxes, you won't see standard or retentive anymore. You will see 45 and 55% insert capture ratios. Colorado, you have anything else to add? I know you were kind of responsible for launching this here in the US.
No, I think you talked to it perfectly. It was just really, like you said, it's talked about differently all across the industry. We really need to standardize it.
Thank you. Yeah, Lana, go ahead, please.
Additional question. When we were chatting with Dr. Sanchez Sotelo, he actually described the Perform Humeral as a flushed inlay, not an absolute inlay. And that opened up another conversation with our commercial staff. And so at some point in time, we probably will have a conversation with them with the difference in how it's perceived or interpreted. But from your side, is there anything that you would say about the difference between inlay and the flushed inlay that Dr. Sanchez speaks about?
Sure. So I know I don't know about the difference between maybe an inlay and a flush inlay, but at least we have started to call this stem. It was designed, we thought, as an inlay stem, but recognizing the collar is right at the level of resection, it's not actually below it, which would make it a flush lay. So that's when I mentioned you put the +0 insert on, you are truly articulating on the surface of your cut. It is a conversation that you may have with your surgeon customers, inlay, flush lay, onlay. So the way we've kind of described it is it's truly a flush lay system. So your articulation's all going to be at your exact level of resection. Dave, is there anything you kind of add? It's funny, Bafan, it's a really good call out because it's interesting how different words can mean different things to different people. But Dave, is there anything else you would add there?
Yeah, it really all has to do with joint tensioning and in making sure you get that proper tension on your reverse prosthesis. And when we started the project, originally the thought process was, looking at other inlay systems on the market. We'll take DJO's prosthesis as an example. Theirs is a true inlay where your sphere sits below the level of resection. That's kind of where we started, thinking that, from a reverse biomechanics standpoint, that maybe makes sense. What we found through all the cadaveric evaluations that we did was that for our stem specifically, oftentimes inlaying below the level of resection oftentimes forced us to build up the polyethylene component more just to get the proper tension. And so when we kind of looked at this and compared our stem to, we'll say, the DJO stem, theirs, while being inlay, the actual metaphyseal body or the proximal body is much larger than ours is. So oftentimes you couldn't fully fit that prosthesis into the actual humerus. So even though it's inlay, you're not actually putting the prosthesis as deeply into the humerus, whereas our design, we were really focused on making it as small as possible. So really, we were able to fully bury the metal component of the prosthesis into the metaphysis, where a flush lay really was adequate. Ultimately, our goal was that when we released this system, we'd be using the stem and a lot of +0 and +3 polyethylenes. We didn't want to use a lot of spacers because that, meant we were probably off on our tensioning and our height. It probably meant we were taking too much bone, things like that. So that's kind of where we landed. And Clarissa in Colorado, you would know much more than I would in terms of what our actual polyethylene usage has been, but I think it has been pretty heavily favored towards the +0 and +3s, if I'm not mistaken.
Yeah, that's correct.
The only other thing I would mention is just from an ease of use standpoint. Originally, like I said, we inlaid the sphere as far as we could. As I was mentioning earlier, the shape of everything changes depending upon what size your glenosphere is. So when we designed those originally, you could sink a 33 millimeter sphere much more deeply into the polyethylene and still maintain a thick enough poly, whereas the 42 millimeter sphere would have to come up quite a bit just to maintain a minimum thickness. Ultimately, we decided this is going to be much easier for users if the tension is consistent from glenosphere to glenosphere, and it's an easily memorizable number as well. So a +0, +3, +6, those are real actual values that relate back to the resection plane. So it really was a combination of making sure the tensioning was right and making the system as easy to use as possible and easy to explain as possible. So there's a very long-winded response, but that was our approach as we designed those.
All right, let's move on to the surgical steps. And you have the instruments in front of you, so please feel free to look at those and ask questions as you go through. So this was designed, as we mentioned, to share instrumentation with stemless. So we'll skip over that today, but we'll kind of start at resection. So you do have a number of different ways that you can resect, again, knowing your markets and what your surgeon customers prefer. So you have an IM guide, so an intermedullary guide, which you can see here. The instruments work for left and right. They'll give you the 135-degree cut. You also have an EM guide as well, so extramedullary that you can pin to the side of the humerus. And then, of course, you can always freehand. We do see a lot of that in the US. Our surgeons tend to like to do that. However, I will say, as you're first launching this, and we did the same thing in the US, we strongly, strongly recommend using the IM guide because it is a 135 fixed neck shaft angle with Perform Humeral. It's not as forgiving as Flex in that you can kind of make some adjustments on the fly. So at least off the bat, I would recommend for your surgeon customers to use the 135-degree IM guide. Maybe over time, once they get comfortable, they can switch to freehand. But it is important to kind of get your head cut accurate with this system. Protect, again, this one's pretty self-explanatory. There's some cut guides you can throw on there or protection plates. Throw it on there and then go to your glenoid. One thing to call out too. You will identify your size. You can see it there in the cut plate, but then on the next size where it says size, you see that color. The color is consistent through the instrumentation that you'll use throughout the case. So once you identify your size, each of them have their own color. So you'll know which instrument you're going to need to use. It'll help you through, at least help the surgical staff as well as you kind of walk them through the case. So you'll move to sizing. And there are two different options here. You can either use the sizing instrument here on the image, or the team designed an alternative option to where you can take one of the humeral heads, put the pin placement guide on it. If you want kind of a more accurate anatomical placement, we see that a lot on the anatomic side, not so much the reverse. Either way, you would see in this place, there's a number 2, so you attach it to that handle, place it centrally on the metaphysis, so long as you don't want to touch the cortical wall. So fill it as much as you can. We have a tips and trick later on. We say large and lateral. So fill the metaphysis with the size that works best without breaching the cortical wall. And then you'll move to reaming. So the reaming, that size again will match the size that used in the previous step when you're sizing. The reamer is, it does have a depth stop, so you'll want to fully seat it to where you can see the kind of that metal rim here. It won't allow you to go any further. So fully seat it, and you will see almost like a wedding cake concavity within the metaphysis. And from there, you'll go down to your distal prep. So you use your awl and your awl guide here. You just take a moment to kind of assemble this piece here and then the handle, and then you'll drop your awl down the canal of the humerus. I will say in the States, you'll see this used if it's not great bone. Some will just take the awl without the awl guide and go down the humerus, but you'll want to be careful with that up front in that it is relatively sharp. So if it's harder bone than you expect, you could cause some unintended consequences through fractures or perforations. So I would recommend off the bat kind of using it as you see here, awl guide with the awl. But over time, don't be surprised if you see your customers kind of skipping that step and freehanding it. Nothing to be alarmed by if it's less than satisfactory bone, but if it is hard bone, I would recommend your surgeon customers to use the awl guide. You'll then move to compacting. So you can see the handle, part of the handle here in the image. So attach that to the appropriate compactor and fully seat it. I will say with the handle, it's the same handle you'll use in final implantation. It is designed to be used both for stem and stemless. The team did a great job on this handle, but it is still heavy. So it is, do recommend when you're in cases that you are keeping pressure to keep it up. Otherwise it will, and it's hard to say this, it will want to fall back. So do be sure to kind of keep it upright as you're seating your compactor in your final implant. Dave, I know, is there anything on that one you want to add at this point?
No, I think that makes sense. And that ties into something I was going to mention on the distal prep side. You spoke to that well, Clarissa. I would say, to your point, that awl is very sharp. It's not intended to be impacted with a mallet. It should be done by hand for sure. The other thing, as you're looking at the instruments, you'll notice on the awl guides, there's a couple of little cut slots on the lateral side. And then you see 2 little tiny osteotomes next to them in the instrument set. When we were designing this, some of the surgeons originally had some challenges when they put the stem down. It would kind of want to fall into varus alignment. And part of that has to do with the fact that the actual stem geometry, the way it's designed, there's a little bit of added material on the lateral side of the stem. So by virtue of that, there's almost more press fit laterally. So to Clarissa's point, when you're inserting with the handle, it's good to kind of keep tilting your hand laterally, I guess, to kind of make sure the stem doesn't go in varus alignment. Some folks, the reason those little osteotomes were designed to begin with is the thought process. If you have the awl guide in there, you could just push those in those slots. That would remove a little bit of the material on the lateral side of your bone preparation. Honestly, they don't get used very often. Most times they get used to the stem with the impactor handle, and they get used to kind of adding that little bit of rotation to the compactor and the stem as they insert, and they get their stem in proper alignment that way.
Good feedback. So then going on to the planing, this is meant to seat over top of your compactor. It just cleans up the cut surface a bit. Honestly, don't see these used a ton either. If you get your cut right, and our surgeons are doing a great job at that, your compactor's in. You may see a few just go over top, but not used very often, considered optional per the op tech. And then you kind of go into your trialing. So whether it's a humeral head or an insert, do take a few minutes to look at the surgical technique on how to move from the modular humeral heads and how to bring them together, the coupler and the head. A little bit different if it's centered or offset, but pretty straightforward in the optech. So again, here you're going to go through and trial either your humeral head or your reverse insert, and then you will do final implantation. Again, it's that same impactor handle, attach it to the stem, seat it, and then you'll impact your final head or your reverse insert. So pretty straightforward from that point. Didn't include a lot of those details here, but if you take a look at the operative technique, it goes through that in pretty good detail. So real quick, these are the trays you have in front of you. These are the 2 trays you would need in any of your cases. So you've got your YCAD 10300. This is all of your core instrumentation that you'll need for the case. And then YCAD 10310 is where you see a lot of your STEM specific components. You've got all of it. Well, the crew there has a lot of the instruments. So take time to look through them, assemble them, get your hands on them before you get into some of your cases. And please feel free to reach out if you have any questions. The team did their best to design it to where it kind of works in order of surgical steps within reason. You got to fit a lot in those trays with minimal amount of weight allowances. But these are the 2 trays that you'll kind of bring into every case. So one call out I'd like to make here is that the inserts that are present are your standard inserts, your 45%. We talked through a lot about our inserts. These may work well in your market, or you may need your 55% polys. That is a separate tray, which we have these tray trial jumper trays that you may need. So the 55% or retentive trays are your YCAD 10350s. I will say, at least here in the US, how they've been doing this is that they will trial with the 45% inserts that are in that stem tray, and then they go straight to a final implant of a 55%. So they're not trialing a lot with these. That being said, some surgeon customers will prefer to trial before they go to a final. What we've seen here in the US is they're comfortable using a 45%. If it's not quite the fit they're looking for, going to a final implant. But it may be wise to kind of look through this and ensure that you have a few of these jumper trays available in your market for those customers that do prefer to trial.
I think that's probably a good thing to note, Clarissa. I'm glad you brought that up. All of the polyethylenes, so whether it's symmetric, 10 degree, 45, 55, 65%, where the actual sphere sits does not change. All that changes is how the rim kind of wraps around the sphere, whether it's angled or not, or how high up it wraps. So the tensioning, the actual tension and lateralization that's happening is the same, regardless of whether you're using different constraint levels, angled versus non-angled. The only thing that changes the tension is if you go from a 0 to a 3 to a 6. So that's why some surgeons feel that they don't need to trial with a 10 degree, or they don't need to trial with a 55%, even if that's what they're using. During the range of motion, they're really just mostly focused on what is the joint tension I'm getting. And that would be the same, like I said, regardless of whether you go from symmetric to 10 degree or 45% to 55% and so forth.
No, that's a great call out. And that's something we did have to learn here in the States as well. A great area to kind of work on this and figure it out and get your talk track around the differences in polys between flex and perform, and that flex was kind of an offset poly. It did shift your center of rotation, which had effects on distalization, which lateralization you would need. With perform humeral, to Dave's point, the center of rotation stays the same on all of these polys. It's just the thickness that changes. So the best way to kind of figure that out in your head, I have discovered, is to get into Blueprint and try to play around in Blueprint, some flex cases, some perform cases, and you'll see the differences in kind of distalization of the stem, as well as what lateralization you'll need to make up for on the glenoid side, which we will get into that here. Jump into some tips and pearls. We've gone through a lot of this already. Great conversation, Dave. Thank you for chiming in with a lot of these. You kind of spoke to our tips and pearls. Stem placement, large and lateral, right? Let's fill the metaphysis up without breaching the cortical wall. And to Dave's point, kind of come in more laterally with your stem to help reduce varus and valgus. So, I mean, studies have shown there's not a huge, whether a stem's in varus or valgus, it doesn't really drive a lot of negative outcomes. However, at least in the US, our surgeons don't like to see a stem in varus or valgus. So the whole large and lateral approach has helped alleviate some of that from happening. It's honestly, varus and valgus still happened with flex. It was just a little less visible because it's more of a curved stem, whereas perform humeral is very straight, as you can see. So it's very obvious if you see that stem, the distal port of that stem tipping, especially since it's more narrow than flex as well. Stem alignment. So again, the whole varus valgus conversation, because of the stem being so small, it's easy to see it slip into varus or valgus. You can kind of take a standard long compactor. The surgeon can use that, pull it out, and then put in their final stem, a shorter stem, and it kind of helps what we say, the tail, the distal portion of the stem, find its way without wavering one way or another. So again, the main takeaway here and what we've messaged largely in the US and Europe is large and lateral. And that seemed to alleviate a lot of our issues, something we had to learn off the bat as we launched here in the US. And then going back to press fit here, and we talked about this initially. So here on the left-hand side, whether you're going from a standard compactor to a standard final stem, or if you're going from a plus compactor to a plus final stem, the usual talk track, if you read the OpTech, that's the flow it will show you. This buys you 1 millimeter of press fit. So you know going from compactor to your final to 1 millimeter of press fit. Now, in the US, where we've seen some differences in the OpTech is we have some users that say if they start with a standard compactor, the bone's not great, and they want to go straight to a final, and they know they need a decent amount of press fit, they'll go from a standard to a plus stem. But what's important for everyone on the call to know is that is 2.5 millimeters of extra press fit. So it is pretty substantial. This is done often in the US. However, we always like everyone to know if you're going to go from a compactor to a final and you're going to skip all the way to a plus stem, it is a substantial amount of press fit. So it is an option that works, but as you're with your customers and that conversation comes up, please let them know that you're going from what would have been 1 millimeter to 2.5. Dave, is there anything extra, or even Colorado, is there anything extra you'd kind of add here?
No, I think you covered it.
Okay. And again, these are when you're in the cases, a lot of customers have to learn this their own way. But these are all good numbers to keep in the back of your mind when you're with your customers and going through the OR, or from a med ed standpoint, training too, is important to highlight. So then the glenoid, and this one is super important. It's something we did learn a bit the hard way, I'll say, in the US. Again, recognizing that there was a learning curve going from flex onlay 145 to perform flush lay 135, is that you absolutely have to lateralize on the glenoid. Unfortunately, I'm not as familiar with your market and what you do in your reverse shoulders, but here in the US, since launching Perform Humeral, we have seen a dramatic increase in a full wedge. It's almost necessary to use a full wedge in most of our cases. And you can kind of see that here on the right with this chart. So this kind of shows the height in regard to your resection level. So if you look at flex being an onlay stem, you are starting at just over 8 millimeters above your resection. And with Perform Humeral, you're starting at 0. So you've got 8 millimeters, at least 8 millimeters to make up here. And where that difference is being made up on is on the glenoid side. So that's where in the US as well as Europe, it's been a large increase in full wedge and that base plates, and that gives you the range of motion that you're looking for. I will say when we first launched it here in the US, we were hearing issues of instability. The joint just felt, the range of motion was just very different. It felt a lot looser than what they were used to. Flex was very tight in the US. Very rare to get a full wedge base plate in without, it took a level of difficulty. So launching Perform Humeral in the US, we realized that difference at your level of resection, that 8 millimeters, has to be made up somewhere. And that's where, and it's part of an inlay stem, right? Is you're moving more towards lateralization rather than distalization. So in the US, I just want you guys to make sure you don't learn the hard way like we did, is that you're going to have to make up that difference on the glenoid side. So in the US, lots of full wedges going in. You can see some other options here. +3s are very rare, maybe some small females. You will see an increase in +6 base plate. And then if you have BioRSA users, you can kind of see a tip here of about 2 to 3 millimeters lateral of your inferior rim. But do be very cognizant of lateralizing on the glenoid when you shift to perform humeral so that you can get the appropriate tensioning of the joint. It is different than flex, so there is a learning curve there. And Dave, and that's not to scare any of you. It's just taking those first several calls here in the US of my range of motion is loose. What's going on here? But it is something I want you all to be very aware of. Dave, Colorado, is there anything here you want to add?
No, I don't think so. To your point, like there's a lot of similarities to Ascend Flex. I mean, that's kind of what we based some of our design on, but it's a very different system than Ascend Flex. So to Clarissa's point, one of the main things we did to improve reverse biomechanics was to allow for lateralization on the glenoid side. So that's really what it was designed for. And a lot of our surgeons took the approach that their first construct that they would try was a +3 base plate, because in that scenario, you could still utilize a lateralized glenosphere as well if you needed additional lateralization. So that was a place many of them started, but to Clarissa's point, many people have gone to really just solely using the 6 millimeter full wedge base plates. They do very, very well in a lot of folks, and that's really how the system was designed to begin with. So it's not Ascend Flex. It behaves quite a bit differently than Ascend Flex by design intent.
Does that make sense to everyone on the call? All right. I know we're running out of time, so we're going to quickly go through kind of what we're seeing here in the U.S. Size 2 and 3s predominantly being here.
We are not in a hurry. Yeah, we are not in a hurry. I mean, it's up to you. I mean, if you have more, don't pressure. We are okay.
Okay. Yeah, perfect. No, that's great. Thank you. Yeah, I've got time if you guys do. I don't want to rush it. I want to make sure you guys
we don't
get
want
what you
to rush as well.
Okay, perfect. Thank you. So stem stats here, collar diameters, your size 2 and your size 3, kind of middle of the bell curve, are what we are seeing a lot here in the US. I will say though, we hear a number of cases with where the size 1 has saved the day, especially smaller females or really difficult anatomy. That stem is small. You can look at the compactor in the tray and see just how small it is. So don't count that one out, but we do see most of our utilization here as a size 2 and 3, which is interesting in that prior to Perform Humeral, the size 1 and 2s were not on the market, right? They're smaller than anything we had with Flex. So it's kind of cool to see that we kind of got the sizing right on that one. And it'll be interesting to see kind of how that shakes out in your market as well. Moving to the right, our short stems here, you can see are overwhelmingly used, almost 80%, occasionally with some long and extra longs, likely in some of those cemented cases. And then something more recently that we have seen is that we have seen a shift from our standard stems to our plus size stem. I think it's just over 50% utilization now. And in those cases, that is where they're using the standard compactor and then implanting a plus stem. They like that extra bite of press fit. And then Colorado, I know, again, you kind of lead this from the US side. Is there anything you'd add on that?
No, I think this is a good slide. It shows how the US is using these implants. I would say that the short stem, obviously, if you look at the screen, looks like it dominates the competition, which it does. But we have seen a slow increase in number of users that are using long stems. So just a heads up there, long stem, it's a great option. Like Clarissa said earlier in the slideshow, it is more of a standard length stem than an actual long stem. So there is a bit of nomenclature there that if you go to a surgeon and say long stem, they might get, they might want to go away from it. But it is a great option if your patient has maybe lesser bone quality. So that's all I would add there, Clarissa.
Great call out. And I have a great chart that kind of lays out all the measurements of each of these stems that I will share after this. To Colorado's point, you'll get to see kind of what those measurements are. like we said, words are funny. They mean different things to different people. So understanding the measurements of each of these will help when you talk to your customers so that, retentive doesn't scare them or a long stem doesn't scare them. Moving on to the next. Humeral heads, kind of to be expected. We see a lot of centered use and a lot of low utilization. Highs are great when you have those cases. Maybe the head cut doesn't quite go as planned, or there's something odd with the anatomy, but centered and low. And here's where you can kind of see those couplers, or they're two separate components that make them modular. And then looking at our inserts, symmetric, by and large, we see a lot of 135 users here in the US. There are still a number of users that very much believe in the 145 philosophy. So you still see around 15% there. I will say that number is a little bit higher in Europe even. I don't remember the number right off the top of my head, but with Pascal Boileau, as well as, and Colorado, you may have to help me here, there's one other surgeon that kind of pushes a 145 philosophy in Europe. So we do see slightly more 10 degree usage in Europe. However, symmetric is still by and large the preferred poly. Looking at the capture ratios here, you see kind of that standard poly, 45% around 40%. Your retentives have moved up to 60%. This has been a more recent shift in the US, I'd say in the last year, since we renamed them and started talking through the measurements of the poly inserts. That's where we've seen more of a shift to that 55% poly. What we recommend in the States is when you go in and you're talking to a new customer, one, recognizing who they use now, if they're competitive, and they use DJO or whoever they use that's not us, what they're familiar with is how you kind of gain your talk track on which poly to use. So in the US, if it's a new customer, typically with this system, we're going in and recommending the 55% poly. However, if once you launch this and they get comfortable with the 45% and they get their range of motion and their tensioning and it works well, it's a great option. But if it's a new customer, competitive business, it's probably best to go in with your 55% poly. And then I think that is all we have on the slides, but I'd love to open it up. Any questions from anybody? Yes, go ahead.
Just a comment on our side. The figures are so different, and to some extent quite similar with what we're seeing in South African market. There is a lesser of a drive on the flex for a 145 degree construct, and so I think the Perform Humeral is really gonna fulfill the needs of those surgeons who essentially wanna still play within the 135 degree angle. Another interesting thing that you pointed is that with regards to the ratio between the standard and the retentive, it's really the opposite in our market, where if I were to equate it to the flex, what we often see is surgeons leaning more to, if I can say, a standard, considering we've got flex, compared to a retentive. So it really starts getting the ball rolling in my forecasting on which direction we want to go. Also with the humeral heads, one thing that we've seen, especially with the PYC, which is a question I'll have about it later, is that there's a greater need for a higher offset humeral head in comparison to a lower offset. But with that being said, just a question with regards to, was there a decision to see whether the PYC can be a conversation actually to determine whether the pyrocarbon heads could be incorporated into the Perform Humeral? Because that's certainly one of the questions that has come up when we told them that the pyrocarbon is not necessarily compatible with the Perform Humeral.
Right. So it's not currently compatible, but you beat me to it. So there is an active NPI project to bring pyrocarbon to Perform Humeral. So it is underway. I think from a STEM side, we are hoping for, at least in the US, and I know South Africa, I think your market can operate off FDA approval. So I'm guessing it's more of a investment standpoint or what your regulatory strategy is, but we're hoping for a 2027 launch in the US for STEM. Now, I will say stemless, that is still TBD. At least in the US, there is no Hemi, so for stemless, yes, there's no Hemi indication for stemless in the US, so it could push us down the pathway of a clinical study. We're trying to navigate the regulatory and clinical world to see if there's any way around that, but right now it looks like it could lead that direction, which would extend the time frame. So in broader leadership conversations, as well as our surgeon customers, a variety of sales fields globally, we recognize kind of the perfect situation would be pyrocarbon on stemless. So we're doing what we can to try to bring that to market. It's just proving to be a bit more challenging from a regulatory pathway, but there is a shorter term plan to try to get pyrocarbon on Perform Stem. And what that means for each of your markets, I'm not sure. That's where Leandri would be able to speak to that more than I could. But at least in the US, I know they're looking for like I think around a Q2, Q3 2027 launch for pyrocarbon on Perform Stem. I'm glad to hear that other markets are discussing that also. That's good to know. Are there any other questions, surprises, concerns, anything that we can help with? Anything funny with the instruments that don't make sense? Because you have Dave on the call and you can blame him if something seems weird. No questions? Okay.
It's a lot to digest too. And if questions come up, like we said, don't hesitate to reach out. I can get on the phone anytime and we'd be happy to answer any other questions.
Zvika, any questions there from your group?
Do you have any question?
Everything fine?
No,
Okay.
we are very good. We played with the set during, so we could actually feel it and see it. Probably we will have some more questions in the future. So with your permission, while we start working with it, hopefully within a week or two, something like that, we will have some more questions. Next week, Professor Maman and Avi are traveling to Professor Scheiber for an LSO to actually see it at work. And hopefully we will be able to start launching within a week or two. So we are very excited. Yeah.
Yes, and it's Professor Scheibel. He's the other that I think prefers a 145. So have him show you a 145 and a 135 when you visit. So no, that is great. And we'll be sure to, I'll send the PowerPoint. Like I said, I have a few other slides in here with some important kind of features and measurements, but please, I mean, Dave, myself, Colorado, we're always happy to help anytime. So just shoot us a note, give us a phone call. We're happy to kind of talk through anything. Like we said, there is a learning curve moving from Flex, so we'd be surprised if we didn't get any questions. But I know Leandri said that this is a very knowledgeable group on the call. So we will send what we have, and then please absolutely feel free to reach out anytime with questions. We're always happy to help.
Thank you very much to you all and for your time, and we'll be in touch. Thank you very much.
Yeah,
Wonderful.
we want to thank you, Dave, Colorado, Clarice. Thank you so much for this comprehensive presentation. It was really amazing. We know that the Humeral Perform is amazing, but the presentation was amazing as well.
Oh, thank you. We appreciate that. Thank you. Yes, thank you
Thank
all.
you.
I
Have
look
a
forward to hearing
great
from you.
morning. See you all.
Yes,
Bye-bye.
yes.
Thank you,
Bye-bye.
guys.
Thank you.
Zvika,
Bye-bye.
Thank
all
you.
the best
Bye.
for you guys. Thank you.
Thank you.
Thanks.
Bye-bye.
Bye.